Thank you very much, Camilla, and thank you very much for the invitation. So I'm really happy to be here. So yes, I will talk about target trial emulation for the evaluation of cluster level interventions. But first, just a bit of background. So I did my PhD quite a long time ago now on the use of propensity score methods in cluster randomized trials. And since then, I've been working a bit on the methodology of cluster randomized trials and also on causal inference methods from observational data. So I'm a bit tired of the fights between trialists and observational people about the best designs, but I think we can combine the best of both approaches, and that's why recently I've been starting working on a target cluster trial emulation. So this joint work with my fantastic colleagues, Camille Maringe, Katie Morgan, and Agnès Kai. So just to give you a brief overview of the content of the presentations, I will start talking about the target trial emulation framework. And I know in this seminar series, there have been a lot of presentations on this topic. So I will try to focus only on the aspects relevant for what I will talk about after. So I will also introduce cluster randomized trials, talk about when it's useful, and spend quite a lot of time talking about estimands for cluster randomized trial, especially now we have a new estimand framework for cluster trials, so that's exciting. And then we'll talk about specific consideration for target trial emulation in this context, and I will finish with an example. So first, the target trial emulation framework, it comes in this context of causal inference. And as you know, often we consider that well-designed and well-conducted trials are the gold standard for causal inference. Of course, not all trials are well-designed and well-conducted. But in practice, trials are not always feasible or suitable, sometimes for ethical reasons, because of their costs. Also, they are sometimes criticized because they have strict inclusion criteria, which means that if we want to estimate effects in underrepresented groups, it may be quite difficult because these patients are not just in the trial, so we cannot do anything. And often they have a relatively short follow-up. So if we are interested at long-term effects of treatments, maybe it's not the best design. And it's in this context that target trial emulation has been proposed as a way to complement the results of trials and not really to replace trial. It's not at all what we are proposing, but really to complement the results. And Miguel Hernan and colleagues presented this framework in this paper in 2016, even though the idea was not new, but the formalization is quite recent. So this is just a graph from a recent systematic review looking at the use of target trial emulation, and we see that it's increasing and it stopped in 2022. Now the number will be much higher. And it's very important because now target trial emulation has a key role for regulatory agencies, and it is described in guidance documents from NICE or from the EMA. So that's why we need to really improve the methodology of these target trials and see what they can and cannot do. So target trial emulation will combine what we like about trials, so their rigor, and we're trying to think in terms of ideal trial. So to answer our research question, what this ideal trial be, and we call that a target. And I will go back to this concept of ideal. And we'll combine that with all the benefits of observational data. So usually large sample sizes, long follow-up time, quite a lot of covariates. And the idea is to emulate, to try to mimic the target trial from observational data. So we are going to apply the principles of trials to the design, analysis, and reporting of real-world data. But let's go back to this ideal. And it's often stated in publications or when people talk about TT, but actually the target trial is not unique. If we give the same research question to different trialists, they may come up with different designs and all valid to answer the research question. So here we are talking about an adequate design and maybe quite simple. If we can do things simply, it's always better. But why are we doing target trial emulation? What's the ambition? And the aims are first to increase the transparency and replicability of observational research, which is true that it's not the most transparent thing. And to help minimize systematic biases by design. So, for example, try to prevent immortal time biases or things like that before doing any kind of analysis and even before looking at the data. And it forces a clear definition of estimands and underlying identification assumptions, so we know what we are doing and what the assumptions we are willing to make to interpret the results. So hopefully it will improve the openness of causal observational research and should facilitate the understanding of between study differences. So if people describe exactly what they are doing, then if the results of studies on the same topic are different, we'll be able to maybe understand why. And hopefully in the future as well, it will help for meta-research because we'll have a better homogeneity in estimate. So it means that we will be able to pull the results for meta-analysis. So target trial emulation is an iterative process. So we start with the research question, so what we want to know. And then we describe the protocol of the target trial that would address this question. So really here, what would we like to do if we could run a trial? And then we describe the protocol for how this target trial will be emulated using our data source. But sometimes we have to go back to the protocol of the target trial because we need to find a balance between what we can feasibly emulate from the data, because we know that there are limitations from the data and we have to work with what we are given, but we still want to have a suitable target trial for that question. So we need iteration, but we don't want to lower the bar too low. So that's why it's quite difficult to know exactly when to stop. And to design this protocol, so there are different components we need to describe. So I won't give many details, but it's just to give an overview. So we start by describing eligibility criteria. So who is eligible for the trial, and we define our target population. Then we define the treatment strategies, and this is very important then when we define the treatment strategy in the emulation to make sure that the consistency assumption required for causal inference hold. We then define the assignment procedure. So in the target trial, it will be randomization, but of course in the emulation, we'll do something else to emulate that. And often we are going to emulate pragmatic trials, and I will talk about that a bit later. We also need to define the follow-up period. So what is time zero? So the start of follow-up, the duration of the follow-up, and so on. And this is very important to avoid time-related biases. Of course, we need to define the outcome, so what it is and when is it measured. The causal contrast. So often people talk about per protocol and ITT analysis, but actually we'll see that we can link that better to the estimand framework, and there are additional components to the estimand that are not really captured by this per protocol versus ITT analysis. And finally, we need to define the analysis plan and to make sure that the analysis method matches the estimand. So actually the estimator is compatible with what we are trying to do. And often it's not the case. So that's why along the way, we need to make sure that everything aligns nicely. And then we do the same for the protocol of the observational study. And we can see for which components we are doing quite well and which components are a bit problematic. And of course, the assignment will be always like a tricky one because we don't have randomization. And in some situation, like the time zero can also be tricky, but I'm not going to talk about that today. The good thing is now there are a lot of other frameworks and guidelines that are helpful to design emulated trials and target trials. So first, the Estimands framework. So for randomized trial, helping to clarify which quantity we are interested in. But also for the causal inference side of things, the potential outcomes framework that will help us express what we want to estimate in terms of potential outcomes and have this mathematical language to write to write a question, and this is usually quite useful. Then for the development of the protocol, there are useful guidelines. So there is a Harper protocol template for real-world studies, and there is also the protocol template for randomized trial that can be useful. Some items can be useful. For the reporting, we have different guidelines as well. So there is a recent target statement specifically for target trial emulation, but the strobe for observational studies, and the CHEERS, which is for economic evaluation. But if the target trial involves some part of economic evaluation, so this tool will be quite useful. And there are also tools for risk of bias assessment, like the Robbins I and the Robbins E. So really using all these tools available only help improving the quality of our studies. So for trials, there are many different designs we can consider. So some trials have parallel arms, some use crossover designs, some use individual randomization, some cluster randomization, sometimes it's superiority, non-inferiority, and there are plenty of other options. And something quite key for target trial emulation, I think, is that these choices for the design are sometimes based on convenience or efficiency gain. For example, crossover trial often is to gain in power. And so it's important to distinguish what is the optimal causal design, so the design which is the best to answer the causal question, and the optimal practical design, which is maybe slightly different, but will allow the trial to be implemented in a pragmatic and feasible way. So just to illustrate that, so if we want to emulate a trial from observational data, we can think about the target trial, which what I will call the optimal causal trial, so what will be the ideal design for my question. But when we use benchmarking, so when we try to emulate a trial to reproduce the result of an existing trial, actually maybe this existing trial is the optimal practical design. And so sometimes we have a difference between the trial that was published and the optimal causal target. And it's not really a problem, but I think to decide what we can or cannot emulate and with which design, we have to think about this distinction. Which aspects of the design are just for practical reason, which aspects of the design are because it's the only way to answer the causal question. So far in the literature, target trial emulation has been used largely in pharmacoepidemiology, not only, but it's where actually we saw great examples. Mostly for parallel arms randomized trials, not only, but the vast majority, and with intervention or treatments delivered at the individual level. But in public health, many interventions or policies are delivered at group level, so delivered at a population level or in a geographical area or within a hospital. And then it's more linked to what we would assess using cluster randomized trials. So the question is, can we emulate cluster randomized trial? When, how, and for what kind of questions? But before I try to address this question, I want to introduce cluster randomized trial and discuss when they are useful and what we need to consider when we design them. So the general idea in cluster randomized trial is that we are going to randomize pre-existing units, so what we call the clusters. So there are groups of people, and so all the participants within that cluster are exposed to the same intervention. So here you have hospitals, and then there is randomization, and some hospitals are randomized to the control group, some to the intervention group. So it means that the patients for this hospital will all receive the same intervention. And in practice, there are many things that can be clusters, geographical areas, hospitals, schools, families, GP practices. There are cluster trials about a lot of different things. But the key thing is within the clusters, everyone, at least in theory, is exposed to the same level of intervention. And as for individually randomized trials, we have different type of designs. So the parallel arm cluster randomized trials, where we randomize clusters and we follow them up. But we also have the crossover version or the step wedge version, where all the clusters start in the control condition, and then at different sequence will switch to the intervention. And in this context, and I'm sure like some people will disagree, but I see these two, so the crossover and step wedge, as optimal practical design that are used to help with some practical aspect of the trial, but are not necessarily the design that are the most suitable for the causal question. So that's why when I'm talking about the emulation of cluster randomized trial for the rest of the presentation, I will focus on the two parallel arm cluster randomized trial. So why do we use cluster randomization? So firstly, cluster randomization is appropriate if the intervention is delivered at cluster level because there is no other choice. So it can be a public health media campaign, a new system for triage in A&E, mass drug administration, so things where actually it's only at the cluster level, there is no other way to do it. Sometimes we also use cluster randomization for intervention delivered at the individual level if there is a high risk of contamination. So either because there is a lot of interactions between participants, and so they may actually not follow their allocated strategy, or in infectious diseases, especially in the study of vaccine, because there is interference, we may want to use cluster randomization. And these two situations is what I would consider a reason for cluster randomization that are linked to the optimal causal design. But sometimes we use cluster randomization to help with the logistics of the trial, simply because sometimes it's difficult to have the different treatments within a hospital, so it can just help with that. And sometimes it's for acceptability, especially if we randomize villages and there is a gatekeeper, maybe they will find more acceptable so that all the people in the village are exposed to the same thing. And this is what I would call the optimal practical design. So it's not, the cluster randomization is not necessary for the causal question, but it will help with the conduct of the design. And often people will say that cluster randomized trials are pragmatic trials. So in a way, maybe they are better suited for a real-world evaluation. But of course, it's great for a lot of reasons, but there are consequences, and mostly statistical consequences, because individuals are nested within clusters, so the outcomes of participants within cluster are correlated, and we'll need to do something about that. And this correlation is often quantified using the intra-class correlation coefficient, so the ICC, that will basically quantify the proportion of the total variance in the outcome, which is explained by differences between clusters. So on the left-hand side here, you have a situation with a high ICC, where within clusters, all the observations are quite correlated, and the cluster means are quite different from the overall mean. But here we have low correlation, and actually there are no difference in means across clusters. And this has like consequences, because as the ICC increases, the power will decrease quite a lot. And there are even situations with a small number of clusters that even if we include more and more participants within clusters, will never reach the expected power. And this is something to keep in mind as well. Then we move to the emulation with observational data, is the power of our study may be quite low. So as I said, we need to account for this clustering, and there are different ways for doing that. The first way is what we call the cluster level methods. And the idea is to say, well, the observations are not independent, but the clusters are. So we just summarize the outcome within each cluster, and then use these summaries using standard test or regression methods for independent data. And these methods are usually quite robust, especially when the number of clusters is small. So, cluster level methods are quite popular. But then we may want to use individual level models like mixed effect models, where the clusters are modeled via random effects directly. And then with regression models, it's usually easier to account for covariates and interactions, but we need more clusters. And the third family of methods is generalized estimating equations, where instead of modeling clustering, it's just a nuisance parameter and we account for it in variance estimation, because we need to basically, when there is clustering, the confidence intervals will be wider. And as I will discuss later as well, Gs are very useful when we have something called informative cluster size. However, and this is very important for what I will talk about in a minute, is by default, if we just use these methods in standard software, they will target different estimands. But good news is all these methods can be adapted to target the quantity you want, and we'll see how. So now let's talk about, I would say, like one of my favorite bits, because it's quite complex, but it's interesting to think about these issues. So just a couple of weeks ago, there was a publication of the new Estimands framework for cluster randomized trial, which is an extension of the existing framework for randomized trials. And some of these concepts were already available in the literature. But the good thing is now we have a very nice way to express our estimates in terms of potential outcomes. So really the language we like and we use for causal inference. So we have that to describe our estimates in cluster randomized trials. However, and some of you will have experience in trying to discuss these estimates with trialists and trying to understand what are these different things, it's very challenging. And I had a lot of very interesting discussions with colleagues about that, and even people working in that area. I find it quite tricky. So I will try without mathematical notation to explain a bit what these things are. So in the new Estimands, the paper, there is this table showing on the left-hand side the original attributes of Estimands from the original framework and the modification for cluster randomized trials. It's mostly the same thing, except that for the population, there is two populations, the population of individuals and the population of clusters. Then when we think about intercurrent events or events happening after randomization, so we need to think about strategies to handle both at the individual level and at the cluster level. And for the estimand as well, so the population level summary, it's where things are interesting because we have marginal or conditional effects, but also we have different type of population we can consider, and it's what I'm going to talk about now. So we can distinguish between marginal and conditional effects relative to the clusters. And this distinction is based on how basically potential outcomes are averaged. But without notation, we can simply try to see that as, for the marginal effect, we also call the population average effect, it's a standard interpretation of marginal effect. So if you know marginal effect, where it's basically like this effect comparing two hypothetical worlds, a world where everybody is treated and a world where nobody is treated, this will be that. Then we have what we call the cluster-specific effect, which correspond to questions such as what would be on average the effect of switching from control to intervention for an individual staying in their original cluster. So here, basically, cluster has a more fundamental role, and that's why it may be often useful in situations where patients cannot really change clusters. So if you randomize, let's say, hospital, potentially patients can travel between hospital and decide. If you randomize families, maybe you are a bit stuck in your family. So this is the first distinction, and note that these two effects can also be marginal or conditional on the covariates, and I'm not going to talk about that. So already we have two things there, for if we consider the effect of covariates. But the second component, which I think is less known, is which population we want to make inference on. And we can either decide that we are interested in the effect in the population of individuals. So in that sense, we give the same weight to each participant, or we are interested in the effect in the population of clusters. And in that case, we'll give the same weight to each cluster. So the first one for the participants, it would be questions such as, does intervention X delivered to GPs increase the chance of patients to receive appropriate antibiotic prescriptions? So we do something for the GPs, but in the end, we want to see if overall the outcome of patients are better. Whereas the other one would be, does intervention X delivered to GPs increase the chance of GPs to prescribe appropriate antibiotics? So now we're saying, okay, we have this intervention for GPs. Do they do better in terms of prescription? It's two different questions, and they may be interested depending on the context. One or the other will be more relevant. And these two quantities or these two estimates will typically differ when we have what we call informative cluster size. So it's when the effect of treatment will differ based on the size of clusters. So an intervention can work very well in small clusters and not at all in large clusters. And in this situation, standard methods for cluster data that are very popular in cluster randomized trials, for example, mixed model or GE with exchangeable working correlation, will be biased to estimate causal effects. So this is something we need to keep in mind, but there are valid alternatives. So either the cluster level analysis I mentioned earlier, or GE with an independence correlation structure. And I will use this method in the example. So this table like that looks horrible, but it's from a paper by a colleague where they are planning to reanalyze cluster randomized trials, and they map every standard method commonly used to analyze cluster randomized trial to the estimand. So I'm not asking you to look what's written there, but the message is, the great thing is whatever the estimand you want to get, you will find a suitable estimator that is implemented in statistical software. Especially the great thing about the cluster level methods is you can find ways to estimate that, to target any combination of cluster specific, cluster average, marginal, and participant average you want. So it means that the choice of the estimates is never driven by the tools available for the analysis. And this is a great thing because you can forget the analysis for a moment and focus on the best quantity for your trial. So now we talk about randomized trial, but how can we emulate target cluster randomized trials? So first, I'm not much in the literature, but there are two great papers. One quite recent on arXiv, focusing on the emulation of step wedge cluster randomized trials, and the other one discussing cluster emulation for the evaluation of health policies. And so they describe very well elements of target trial emulation for cluster designs, but they focus mostly on difference in differences, which is a slightly different framework, whereas what I'm going to talk about is really about the analysis when we have individual level data. And in these two papers, they frame the estimates in terms of average treatment effect on the treated, but there are limited links to the estimate frameworks and the methods. So that's why I think there is more to do in this area. There are also a few examples of paper who use target trial emulation. So this is the first one for dengue control, and another one which is a target trial protocol. They both describe very well their emulation. So I'm hoping that in the future there will be more and more studies trying to emulate cluster randomized trial and done in a very nice way, like these ones. But I want to stop a minute to think about additional considerations for cluster target trial emulation. So most of the components of the target trial will be the same, but in a way everything will be doubled in the sense that eligibility, exclusion, treatment implementation, everything will be described both at the individual and cluster level. So it's not more difficult, it's just that we need to separate both aspects because it won't be the same eligibility criteria for the participants and for the clusters. Then, because we are working with observational data, and it's true as well in trials, but we need some assumptions for causal inference, and we'll see how, to which level they apply in cluster randomized trials and emulated cluster trials. The first one, which will be probably the more problematic for the emulation, is consistency. So it means that for a cluster K under a specific level of intervention, the potential outcome for that intervention is the same as the observed one. And this is linked to a good description of the intervention. And the problem is with observational data, for complex interventions, like the type of intervention we assess in cluster randomized trials, there will be a lot of ways the intervention is implemented. And for the same core intervention, hospital A may do something a bit different from hospital B and so on. And I think this is almost unavoidable when we are looking at complex intervention or policies, or these things are so complex that actually there are slightly different versions of the intervention. Then we have the assumption of no interference, which means that the potential outcome for our clusters are independent of the intervention received by the other clusters. I think this is usually not too much of a problem. And then we have conditional exchangeability, which is the absence of confounding. And here we need to have basically all the individual level and cluster level confounders measured and appropriately accounted for in the analysis. And the last one is the assumption of positivity. So given a set of variable, then the probability to be exposed to any intervention level is a non-zero. And again, it's something we can think about at the design stage. But where things become extremely complex is when we go back to Estimands, because we have first the Estimands for cluster randomized trials. So this new extension with already this complex framework. But now we also have an additional layer in observational study, is the target population. Do we want the average treatment effect for the whole population, or the average treatment effect among the treated or the untreated? So this is an additional level to the estimate. And then we also need to think about what we want to do for intercurrent events. Do we want a treatment policy strategy, so similar to ITT, or something else? And then we have to think, okay, but I have covariates. Do I want something conditional or marginal? And this is all put together. It becomes quite quickly not a nightmare, but it's a bit challenging. And this is quite important because based on these choices, the estimate at the end can be quite different. So you have to make sure your choices align with exactly the question you are trying to address. We also have some specific data requirements. As I said, so cluster randomized trial can evaluate interventions that are delivered at the cluster level or at the individual level. So it means that the target trial could do two. However, when we work with observational data, it's very unlikely to have one level of treatment only per cluster if the treatment is something that can be delivered at the individual level. So for a drug, for example, you won't have this structure in the data. So it's where actually thinking about the optimal causal design and the optimal practical design may be helpful. So it means that only cluster randomized trials for cluster level interventions may be emulatable. I'm not sure it's a word, but we, in most cases, will only be able to emulate cluster randomized trial when the intervention is actually a cluster level intervention. The problems are, or it's not a problem, it's something we need to be aware of. we need a number of clusters which is sufficiently large. As I mentioned, if the number of clusters is too small, sometimes we cannot achieve like an acceptable power, and we may have issues with type 1 error rate as well. We need to have sufficient information about the clusters and the participants to control for confounding. And sometimes it's a big limitation. And we also need to have in the data sufficient description of the intervention, because as I said, like this intervention we evaluate with cluster trials are quite complex, multi-components, and often just a variable that say, oh, yes, no, won't be sufficient to actually understand what we are doing. So we need to have more like a qualitative information about this intervention to help with interpretation. Okay, so now I've briefly talked about specific considerations. So I want to finish with an illustrative example. And first, a bit of background. So it's an applied example in cancer. And non-small cell lung cancer is the most common type of lung cancer. And if it's diagnosed at an early stage, usually stage 1 or 2, surgery is the recommended treatment. But we know from published work that there are inequalities in access to surgery. In particular, women, older people, and people living in most deprived areas are less likely to access surgery. And we saw that maybe cancer nurse specialists who are there to support the patients could help remove some barriers in access to treatment. So in the UK and within the NHS, cancer nurse specialists have a key role to help patients through their cancer journey. And it's about information, monitoring, but psychological support. So it's really multi-components. And there are some guidelines, so nice guidelines for the number of lung cancer nurse specialists that should be available. And the recommendation is 1 full-time equivalent cancer nurse specialist for an annual caseload of 80 patients. So what we wanted to know is what's the causal effect of an adequate provision of lung cancer nurse specialists on patients' access to surgery. And what we call adequate is using this threshold of 1 nurse per 80 patients. So, of course, we couldn't do a trial to answer this question. So we used England Cancer Registry data, which contains individual level data on patients diagnosed with lung cancer. And we focus on 2017 because in 2017, Macmillan, which is a cancer charity in the UK, did a survey asking NHS Trust to describe all the available posts of cancer nurse specialists within the trust. So we had this survey with quite a lot of information on the type of post, the FTE, the setting, and so on, the time they spent with the patients or doing admin tasks. So quite complete survey done in 2017. So we merged these 2 data sets on the NHS Trust Code. So then our emulated target trial had this structure. So we had NHS Trust. Some had a provision of lung cancer nurse specialists below target, some at target or above target. And then within each trust, there were some patients diagnosed with early stage lung cancer. So this is a table comparing the different components for the target trial and its simulation. And I will only comment on the most interesting components here and where like there may be problem or differences. But the design of the target trial is a cluster randomized trial, open label, it's a superiority trial with 2 parallel arms, and probably, ideally, we would stratify the randomization on whether the trusts are specialized cancer centers. Whereas for the emulation, so it's a cohort study using observational data, and we're trying to emulate a superiority cluster randomized trial. So then we have eligibility criteria at trust and at individual level. So they are roughly the same. And in terms of exclusions, in the trial, we would only include clusters that don't have yet cancer nurse specialists. Whereas in our emulation, actually, we had only the description we have for 2017, so we didn't really know what was available before, which is a main limitation of this work. And we excluded trusts for which we didn't have any information on their nursing workforce. So if the trusts were not in the Macmillan survey, we couldn't include them. So then the treatment strategy in the target trial, so it will be the introduction of one cancer nurse specialist for 80 patients per year versus usual care. In our emulation, it's one or more lung cancer nurse specialists for 80 patients versus less than 1 per 80. Of course, we don't have randomization, so we try to achieve conditional exchangeability using cluster level and individual level variable. But really, what's the challenge in this study is consistency, because we have information about the FT, so how many nurses were there, but we don't know how many patients they are in direct contact with, and if most of their work is admin or if it's time spent with the patient. So for the consistency, it's a bit tricky. So here we are just capturing the causal effect of their presence. Is it changing something in the way the trust look after the patients, basically? And this is probably not the well-defined question, but at least with the data we have is the best we could do, and we are aware of this limitation. So the outcome was the individual receipt of surgery with curative intent within 6 months of diagnosis in both situations, and the follow-up started at diagnosis and lasted 6 months. So in terms of estimates, so we saw that our target population was a whole population, because if it's to inform like policy, we want to know, okay, is it what's like the situation where we have a world without this provision of cancer nurse specialists versus like cancer nurse specialists in all trusts. Then we also focus on a population average effect rather than cluster specific, because we know from previous research that cancer patients travel substantially across hospitals. So actually they are not really stuck where they are. So maybe population average is more relevant in this situation. And as a start, we saw that maybe we are interested in the effect for the population of clusters rather than participants. Also, of course, we want to see the effect of participants. But maybe the question is, if the intervention were like rolled out, how many trusts would improve their quality of care, or give like or at least how many would increase the proportion of a patient treated with surgery. With regard to adherence, we focus on a treatment policy estimate corresponding to an intention to treat analysis, simply because, well, first because for policymaking it's probably relevant, but also because we didn't have data on adherence anyway, so we were a bit limited here, and we decided to express our treatment effect as a risk difference. So we had some variable at cluster level, like the cluster size, the number of patients diagnosed in the trust, whether or not the trusts were cancer centers, the total full-time equivalent of cancer nurse specialists, and some information we got from the internet, so the Care Quality Commission rating. So it's ratings about the performance of the trust. So there are different components, whether they use the resource well, whether the patients are safe, and so on, that capture how well the trusts are doing. Because we saw that actually maybe more resources and more nurses were allocated to trusts that maybe were not performing very well. And we also had patient-level characteristics, so age, sex, comorbidities, deprivation, performance status, and stage at diagnosis. So this is a tag, and so it's very small, so the idea is not for you to look at every single variable. But assuming this tag is correct, the interesting thing is the minimal sufficient adjustment set to estimate the causal effect of the provision of nurses on our outcome only includes cluster level variables, which is not too surprising because actually the trusts are quite large and there are not many differences in terms of patient characteristic across trust at this higher level. So only the CQC rating, whether or not the trust were cancer center, and of course the trust themselves were needed for adjustment. But to gain precision, we also adjusted for some individual level variable associated with the outcome. So this is the flowchart. Sorry, again, it's small, but we started with a lung cancer patient diagnosis in 2017, excluded the emergency presentation, people who had missing stage at diagnosis because it was one of our eligibility criteria, and excluded late stage. We also had further exclusion because some patients had no trust code information, so we didn't know to which trust they belong. And also some trusts were missing from the Macmillan survey, so we excluded patients from a trust for which we didn't have any data. So an interesting thing, if we look at covariate balance between groups, so we had 116 NHS trusts. And if we look first at individual level covariate, so stage, age, sex, and so on, there is almost no difference between the two groups and the covariates are well balanced. So we are not worried about confounding on individual level covariates. However, for cluster level variables, there were some difference, especially in the control groups. So clusters below target were usually bigger and more often cancer centers. So big centers with a lot of expertise. And on the other hand, the clusters in the intervention arm with more nurses were the trust not doing very well in terms of performances, so which reinforced like our thinking that maybe the resource allocation was based on performance. If we look at the cluster level distribution of lung cancer nurse specialists, so the dotted line is the threshold, so our NICE guidelines, and we see that except for a few outliers, it's roughly like normally distributed. So we had 67 control clusters and 49 intervention clusters with 5,000 patients in the control arm and 2,000 in the intervention arm. Then we looked at the distribution of the outcomes, so the proportion of surgery per cluster. So in red, you have the control clusters, and in blue, the clusters with a number of nurses above target. And there is a lot of clustering there and stronger in the intervention arm with an ICC of 0.1, whereas in the control group, it's 0.08. And it doesn't look a bit like that, but if you are used to cluster randomized trials, these values are actually very, very big. So it means that a lot of the variability in access to surgery is explained by differences between clusters. So then, although I specify our estimate of interest, we also wanted to compare different methods for illustrative purposes. So we compared a cluster level analysis and a G with or without adjustment for confounders. Either giving the same weight to every patient or the same weight to every cluster, to estimate risk difference or odds ratios, and to estimate marginal effects versus cluster-specific effects to illustrate whether there are differences in that situation. And actually, there's not many differences simply because there is no intervention effect. And whatever the estimate, 0 is always 0. So that's why the results are not that exciting, but there are still something we can get from this. First, is that when we adjust for confounders, so this one and this one, we get closer to the null, so there may be some small confounding. And from the standardized differences, it was not massive, but we're still correcting from something. Then, when we look at the population for inference, we see as well that when we give the same weight to each cluster, we get closer to to the null as well. So because of the difference between the result in blue and result in red, maybe it indicates that there is maybe a little bit of informative cluster size. And although some people are just happy to say that and then maybe stratify the results, I think when it happens, even if it's not massive here, it's important to think about whether we see that because there is a residual cluster level confounding, and actually it's because there are some important cluster level variables that are not in the analysis, or it's simply because of violation of the consistency assumption. And actually, maybe the intervention in small clusters is not at all the same as in large clusters, which is quite plausible because in small clusters, maybe the nurses can actually know all the patients and provide more support, whereas in very large clusters, maybe it's less personal. So that's why we need to think about the mechanisms behind that as well. And we see that with adjustment, we gain a bit of precision with the confidence interval a bit narrower. For the odds ratio, it's quite similar. Also, the gain in precision with adjustment for covariates is even more pronounced than for risk differences, but it's similar patterns. And because we are very close to the null anyway, we don't observe huge differences between methods. However, it won't be always the case, so that's why it's very important to make sure that you use the right method for your estimate, because in some situation it will actually matter. So just to conclude, when we have intervention targeted at cluster level, we can emulate cluster randomized trial, and we just need to account for clustering in the analysis. The consistency assumption will often be your main problem. However, if you have in your data sufficient information to describe the intervention and use it for the interpretation, it can be fine. It doesn't mean that you shouldn't proceed with the analysis. It may still give you something useful in practice. But the main point is really that you have to define clearly your estimates to align with the research question. So think about this distinction between population average and cluster specific, marginal and conditional on the covariates, and marginal and conditional and equal weights to participants or to clusters, especially if you think you have informative cluster size. But good news is that now there is this estimate framework for cluster randomized trials, and this combined with other resources will help guide you in with your design. So just a final comment. So we hope that target trial emulation will lead to huge improvements in the quality of observational research. But if you can do a pragmatic trial, cluster randomized or not, do it and don't use target trial emulation as a replacement. And in a similar way, if you are doing epidemiology and you are using observational studies, don't immediately jump into target trial emulation. There are also other designs that can be used. So target trial is very trendy at the moment, and for good reasons. It has a lot of advantages, but we need to justify its use carefully. And because there were other trends in statistics with at some point people wanted to use propensity scores everywhere, or in trial people wanted to do stepwatch trials everywhere, and we just need to justify why we want to use this tool versus another. But that's it. Thank you very much, and I will be happy to take questions.